All right, today we are diving into two really fascinating and pretty rare conditions that affect the blood vessels in our kidneys. We're talking about renal artery aneurysms and arteriovenous fistulas. Let's get right into it. So picture this. You go to the doctor for something totally unrelated, maybe some back pain, and they do a scan. And then they find something else, something you had no idea was there. That's actually how most of these conditions are found, completely by accident. And suddenly, you're faced with a really tough decision. Okay, so let's start with the first one, the renal artery aneurysm, or RAA for short. What in the world is it? This analogy is perfect. Seriously, think of the main artery going to your kidney like a high-pressure hose or a tire. And RAA is basically a weak spot in the wall of that artery that starts to bulge out. It's a really simple but powerful way to understand what's happening and, what the potential danger is. Now, before you get too worried, you should know these things are incredibly rare. I mean, look at that number. When they do big studies and scan a ton of people, they find these in less than 1% of them. That rarity is exactly why they're almost always found by surprise. And of course, it's never simple, right? Not all of these bulges are the same. Doctors have different classifications. The most common kind are called saccular. They look kind of like a little berry hanging off the side of the artery, usually right where it splits. Others are shaped differently, and some, called dissecting aneurysms, are actually caused by a tear inside the artery wall itself. And this gets us to the real heart of the issue for doctors. When they find one of these rare, quiet aneurysms, what do they do? Do you jump in with a potentially risky procedure, or do you just watch it and wait? That's the big debate. This slide is a perfect example of how medicine is always learning and evolving. For years, the rule of thumb was pretty clear. If it's bigger than 2 centimeters, you fix it. But as they gathered more and more data from watching these things over time, the thinking started to shift. The evidence showed the risk of rupture for smaller ones was super low, so the guideline moved to a more conservative 3 centimeters. And you don't have to take my word for it. This quote from the experts who studied this really says it all. They looked at all the evidence and basically concluded that the old rule was just too aggressive. The risk of the surgery was often greater than the risk of the aneurysm itself, especially for those in that 2 to 3 centimeter range. So, for most people, watchful waiting has become the new standard for smaller RAAs. But, and this is a huge but, there's one specific group of patients where this entire debate, all these guidelines, they just go right out the window. And that exception is pregnancy. The hormonal changes, the massive increase in blood volume, it all puts a tremendous amount of stress on the body's blood vessels. And if one of these aneurysms ruptures during a pregnancy, the outcome is just catastrophic. I mean, look at those numbers. A 55% chance of the mother not surviving and an 85% chance for the fetus. The risk is just unthinkably high. So, because of that absolutely terrifying risk, the playbook is completely different for women of childbearing age. If an RAA is found, no matter the size, the recommendation is to repair it, period. The goal is to get that risk off the table before a pregnancy even begins. For this group, there is no debate. It gets fixed. Okay, let's switch gears to our second topic. So if an aneurysm is a bulge in the plumbing, our next condition is more like a short circuit. It's called an arteriovenous fistula, or AVF. The plumbing analogy works great here, too. An aneurysm is a weak spot in a high-pressure pipe. A fistula, on the other hand, is when that high-pressure pipe springs a leak and connects directly to a low-pressure drain pipe right next to it. This shouldn't happen. It creates this tangled, high-flow mess that can cause some pretty big problems. Now, here's something that might really surprise you. You'd probably think most of these are congenital, something you're just born with, but the data shows the exact opposite. Over 70% of these are acquired, meaning they're caused by some kind of trauma. And the most common cause? A kidney biopsy. Yep, the very procedure used to figure out what's wrong with a kidney can sometimes cause this problem. The good news is, just like the aneurysms, most of these AVFs don't cause any symptoms. And a lot of the ones caused by biopsies just heal up on their own over time. But when they do cause symptoms, they can be serious. We're talking everything from blood in the urine and really high blood pressure to, in really big cases, even congestive heart failure, because the heart is working so hard to pump against that short circuit. So whether we're talking about a bulge or a tangle, when a doctor decides it's time to intervene, how do they actually fix it? Well, the approach here has changed a lot.
You basically have two paths, the old way and the new way. The old way was open surgery, a big operation, a long incision, and a much longer recovery. Today, though, the vast majority of these are fixed using endovascular techniques. This is the high-tech stuff. They go in through a tiny puncture, usually in your leg, and snake these little catheters all the way up to the kidney. From there, they can deploy tiny metal coils or even a little covered stent to seal off the problem from the inside.
So the bottom line here is that the game has completely changed. This less invasive endovascular approach has become the go-to, the gold standard for pretty much all symptomatic fistulas, and it's becoming the top choice for aneurysms that need fixing too. Okay, I know that was a ton of information, so let's just boil it all down. What are the most important things to walk away with from all this? Let's do a quick recap. First, both of these things are super rare and usually found by pure chance. Second, for aneurysms, that magic number for treatment is moved from 2 up to 3 centimeters. Third, that rule gets thrown out for women of childbearing age. Pregnancy risk means you fix it. Fourth, most fistulas are caused by trauma, not genetics, and lots of them heal themselves. And finally, treatment for both has made a huge shift away from big open surgeries to these slick, minimally invasive repairs. Which kind of leaves us with one last interesting thought to chew on. In a time where we have all this amazing technology to fix things, the science for these rare conditions tells us that sometimes the bravest and smartest thing to do is to simply watch and wait.